The common themes I've been hearing have something to do with connections, measurements. We're looking at something, we want to know how well it works. And if I am an expert witness, if I'm an expert witness for the court, or if I make a report and there's a problem a couple of generations next when it wanders through these systems, because of something I didn't do, I need to know about it. Otherwise, I'm not going to get better at what I'm doing. And part of what we will be building, as best we can, is connections. With the Hipaa, there's a Hipaa guide that we've got, it's been inspired by this DCFS hospital thing, that talks about exceptions to Hipaa. The common time that you can share information, it lists all this, and this, and it says, for the purposes of preventing child abuse. If I know something, and if you knew it, or if you have something, if we stuck our things together, I will tell you our first child death case. Mom, boyfriend, baby. Baby's dead. Boyfriend's in jail. Case is presented. That's, the boyfriend probably killed the baby. And then someone to my left said, that's not the first kid to die in that family, from another agency. Someone across the room says, you know, that child was injured before. But nobody had those three critical pieces of information. So we're going to be attacking all of that. In theory, I think we're coming up to, help me out, Paul. We're going to have questions. People have been writing questions down. Do we have some
Well,
questions?
hopefully, if anybody has questions, now's the time. A couple other announcements. You have in your packet an evaluation form. Please fill out that evaluation form and turn it in at the table out here on your way out. And the database that you heard about at the beginning of this conference, the people are still here. They're outside. If you want to ask them any questions at all about that, you're welcome to do so. And now, if you have questions, go ahead and raise your hands. And I think most of our speakers are still here, so they can answer your questions for you.
Okay. Who has a question?
I just want you all to know that those lovely wrapped cookies at your table and the cupcakes were created by a 16-year-old little girl who is the daughter of a neighbor's housekeeper. And they worked and worked and worked so that they could bring them here today and share them with you, because they want to be part of the answer. And the one little girl says, I want to be a social worker. I want to be a social worker who works with children who are abused. So I think their names are on the back. And if any of you have an event or whatever where you might want to have these cookies or the cupcakes, please let us know or call the number on the back of your cookies, because it will be very important for these kids. And this is also her only separate source of income. So thank you very much. And if any of you tells an official looking person around the endowment that these cookies and cupcakes were brought in by ICAN, we will deny it. So please take them with you if you have extra ones at your table, and let us know if you want more for another event.
And those on the internet, we're sorry, we can't send you a digital cookie. But we have some questions. Someone had a question?
I have a question.
Yes.
So when I left to go to medical school and everything, you know, I thought that collaboration was going to develop as the cultural value, really, of ICAN and of the county. And I sort of believed that until I got to be a grown-up doctor, and then I, you know, began to understand it better. But one of the things I did in my research network that I really want to urge people to think about was I got a first class, and I mean international class, data coordinating center. They have them in Washington. We called them, we had a little name for them, we called them Beltway Bandits because they'd find, you know, your project and then they'd bid on it. But I actually found one at a university, And I think locally you might have it too. And I got a data manager I got a biostatistician that had done the angioplasty trials, and now he had children and wanted pediatric studies that were meaningful. I got really first-class help that way. Research nurses and research nurse training, all of these things, and I set aside some money for it, and that's what attracted their attention. But I wonder, in reinventing the wheel all the time with systems that don't communicate with one another, so like, for example, the Hipaa concern. This data is stored in a mountain in Utah on the Colorado border and guarded by the Department of Defense, okay? No one is going to access it that is unauthorized. So I just wonder, in making making systems that have a border around them, do you not sort of make it harder for you to do what you're doing?
I'm sure I make it harder, and I'm not sure how it is. I don't make sense sometimes.
No, I'm just wondering. I mean,
But
wouldn't you like
if-
something that...
No, but if you look at it and you say things like, how many kids died, what did they die from,
Right.
what do we know about families that have a kid who dies from abuse? And the answer is that little pieces of information. We did a study in the early part of our first round with hospitals. We were collecting the data on 0 to 3 years old that were inpatients, and 0 to 3 years old that were emergency departments. So we had hospitals looking for those cases. It is not science, but we found some things that are very important in terms of management, and that is there's a difference with reporting child abuse from the emergency department than reporting from an inpatient intensive care. And there was at least 2 hospitals where the social workers had trouble with the report from intensive care because those doctors have a different knowledge-based blood gases. They keep people alive. And the child abuse doctors are, besides having an education, they tend to be fairly passionate people about what they're doing. I think there we can tag a bunch of things that we ought to be measuring. The question is, can we present it? And I'll be calling you, Carol, because you speak so clearly. You and this other Carol. Both Carols, you just have a clarity that I lack. Anyway, but you have a... Anyway, does anybody else have a question? Carol.
I want to respond to Carol, and then I have a question for her. Because I think there's a difference with research data, sort of research data and having it and storing it, from having data like in real time that I can access it within a minute, just like Clay was saying, and find out, is this something I have to do? And I think the resources for that are totally different. We have the data management thing at LA Biomed. We do massive research. You can have registries. You could have all that private patient data and aggregate it and make predictions. It's totally different from having access right away to help you make a decision about an individual patient. So I think that's what the challenge is.
I agree with you that that's the challenge. However, with the amount of money that's being set aside now for big data analysis and science analysis, I think that such systems are going to be integrated soon, and that there's tremendous funding and interest in Washington in facilitating that. So that if you want, for example, just at an intersection, for example, if you wanted to look at how many private hospitals, making this up, how many private hospitals had social worker reports of child abuse from the nursery, okay? That you could get granular, or you could move back out. And there are systems that have been that are being developed now, and I think it's important that they be developed in a responsive way to a multidisciplinary problem such as ours. Okay,
And that, I
that's
mean,
all.
that data is fine. I'm saying the data is Mrs. Smith, who has a baby now and tells me she's never had any other children, and I want to find out, did she have other children or were they taken away? I think that is definitely more challenging.
I think
Yeah.
that a sophisticated data system could handle it. And I think you could build bridges across it. For example, there's something called the E-room that can be built across systems, and you can control access to the E-room in various ways. You can post papers to one another from distance. You can alarm one another. You can say there are 50 people with spots on their heads in the ICU today in Los Angeles. You can build those junctions, and all I'm saying, I'm not saying they exist in large amounts. I'm just saying the technology from our data colleagues exists in a way that we don't understand that. For example, the PICU I trained in at LA Children's, they downloaded per child 200 pieces of data per hour. So then that was clinical service data, somebody's blood pressure, their respiratory rate, whatever. And that data became essentially useless because it was compartmentalized, okay? It was part of the medical record. And now what we have to do is make a way that you can access that for research or for service. I think that they're going to be the same thing, that's all.
Right. We find a lot of our research data has to be de-identified. If there's any means of identifying an individual, it has to be deleted or it doesn't get approved from our RRB. But I had another question for, it's about all that wonderful trauma data.
Yeah.
And I would just make a suggestion that we don't limit ourselves to looking at non-accidental trauma. And that look at other causes of maybe preventable injuries in children as part of a bigger picture. Because more children die from accidental injuries than from non-accidental trauma, and we can make a real difference in the lives of those children.
Absolutely. You can see the percentage of critical trauma is a huge thing, and I think that just even within that, there are many questions that can be answered. And I think informing practice about an individual patient or child can be facilitated by understanding those.
Oh, I think we're going to have some exciting times. What I have found is that you can have the measurement. People could say a long time ago, if you don't want to have epidermoid lung cancer, which is the most common type, don't smoke. And nothing happened until finally we got famous people who were dying, and now, people still smoke, but you don't see them, and you don't have ashtrays here. There's a university up north that has a sophisticated children's hospital that was making about 40 to 70 reports a year. And they suddenly they doubled. And the question was, why did they double? Well, they doubled, I think, because the child abuse doc went there to have that sophisticated university on his resume, got on the scan team, and stayed with it. They made him chair of the team, and he doubled their child abuse reports. I think that is clearly a significant piece of information, but it's hard to get it with not the research money, just the management money to make a difference in that. We used to have an accidental death review in this county, but when the bad economy came along and the ICAN staff went from 6 social workers to 3, we lost that team. We should have that team back, you're right. Anyway, we have a question, yes.
I had a question, but I realized Ruby could answer it, so I just leaned over and asked. I was interested in the CART program. It was free for 90 days to a willing participant in a pilot program, but having just gone through the body-worn camera issues with TASER, it is the aftermath that knocks you down. So I wanted to know, if we had determined what the monthly or annual costs would be for continuing the service going forward. And then secondarily, and Deanne sort of answered this one for me, I wanted to know if it was an, an intramural or an intermural program, such that, was it just an individual hospital could record its own data and figure out if a child had been there previously, or, and this of course would be the ideal, could every hospital in the system know, because we've seen certainly in death review how families go from hospital to hospital to hospital, really in the hope that their prior abuse won't be discovered.
Well, no, and there's a program called LANES, which is another acronym, that is building a system to catch, as I understand it, all of the Medi-Cal money spent on healthcare, positive, I mean, public, private, everybody that's getting it, and could use that to detect things. I think with all of those, I would not be surprised to find people that are not that excited about what we're thinking of doing. The basic theme is you're going to protect records, you're going to protect kids. The push is you protect the records. The Centers for Disease Control has an annual report on sexually transmitted diseases. They have a graph by age. Over 65, hardly anybody has gonorrhea. That kind of makes sense. As you work your way down, you get to 10, and under age 10, they just left it off. How can you do that? And these are good people. These people aren't bad. Is they're saying, well, we didn't want it to be misunderstood. There are toddlers who have sexually transmitted diseases. There are toddlers who are HIV positive and the mother isn't. So it isn't a matter of fetal contamination. There's a whole series of amazing things then that I think we can do. I do make a split between research and management. I think it's important that LIC USC to know if the burn service reports. Not LIC USC, just the burn service. If you've ever been on a children's burn ward, it's a painful place to be. And some, not all of them, just some of those are intentional or at least shouldn't have happened. And how can we deal with those? Well, the first thing we do is we get SC, Torrance Memorial, and West Hills Hospital need to visit each other, see their program, and get excited about talking to each other. We then throw in Arrowhead in Colton and UC Irvine in Orange County. That's 5 burn hospitals talking to each other, and they will take us someplace. And with some help, we can measure it. I think the best measurement child abuse program is the ACE study, Adverse Childhood Experiences. Fellow set up in Kaiser, Southern California, which is a big healthcare system. And he said, I want everybody when they come in the next 6 months, something like that, what was it like in your first 3 years of your life? Did you get beaten, molested, your parents died, your dog died, whatever. And they collected adverse childhood experiences. Now, they did a beautiful, sophisticated study about showing that these people had a higher incidence of cancer, they're more apt to smoke, liver disease, they're more apt to drink. But the pretty one they had up front. So you take a patient here, you get the adverse experiences, you go back 6 months. How many times did they come into the emergency room or the clinic? The fact is, if you're depressed and lonesome, one of the things you can do is be sick, go see some medical person who will touch you and frown with great concern, and you feel better. So they took, here's how often these people came in, and now in the next 6 months, boom, it drops. That's a money maker for Kaiser. It didn't set any fires yet, but we can show that we can do things and make it less expensive, at any rate. Oh, why don't I let Ruby go? Well, let's see. Why is it I won't let Ruby? Okay.
When we do our research regarding servers and technology or HIPAA compliant processes for technology in terms of transfer information storage, It costs anywhere from $3,000 to $20,000 a month just to maintain servers. That doesn't include technologists, doesn't include front-end developers, doesn't include someone to wake up in the middle, reboot the system because it's crashed. So when people ask me, what do you need? I said, well, basically, frankly, if you can pay for the servers, I'm good. Let me handle the technologists, the programmers, the engineers. Let me handle that. Just pay for the servers, I'm good. Because it's very important, extremely important to create and maintain information behind HIPAA-compliant firewalls. Because if you have one break-in, the system's gone, it's shot. So I'm willing to look at how do we create the most secure method to do this, to make it work for a collaborative process. Again, this is Dr. Turfy's dream, and I met him in 2000, and I'm dedicating this work to him because he deserves it. I also reached out to Maribel Marin, the woman next to me, because she has expertise in data storage. She does a lot of things with storage under AWS compliance. She is certified in HIPAA compliance, and she's my subject matter expert amongst all of them. I also reached out to UCLA. I reached out to USC already. I went to USC campus and spoke with the computer engineers, data scientists, in terms of how do we look at data visualization processes. I went to Stanford. I did a presentation at Stanford twice on how they use technology. So I am actually going to universities and asking their research departments and professors how is the best way to serve data from end user engagement to the institutions. And the first thing that you keep on telling me is you have to make sure your storage is compliant and secure. Unfortunately, that, again, I said it's a very high cost. And so people are asking me, well, why is it a cost? Well, we just can't have data just floating in anybody's server because it's not going to work. And so I'm very, very keen on how we make this work from a security perspective. Also, another piece too I want to talk about real quick, injuries with children. I'm a child abuse investigator for LA County, and I actually had a case where a child died, and it came as accidental through LAPD. Based on information that I was able to obtain, there was an actual death 4 years prior, same age of child, same mode of death. And based on the information that we shared, we found out this was homicide. But it's not the first time I go out and I see cases upon cases when they appear to be accidental. It happens a lot when you have resident doctors, and it's on a Saturday, and there's high workload at ER departments. So I do have the experience to look at child fatalities, severe injuries, but a lot of social workers, police, fire department folks don't. So we had an ability to share that level of information in a granular sense, clean the data so you don't have no first name, last name, but do it in such a way that your library, an indexing of injuries. So when someone comes across to a particular scene, they have a point of reference. So when a parent says, oh, this kid fell off a couch, a skull fracture, and the couch is 2 feet from the ground, and you're brand new, you may believe that because you're clueless. Not that you're clueless, it's because you don't have that point of reference. But then you have access to a mobile phone that tells you 89% of the time, that's false.
Anyway, Ruby's so funny. Ruby wins these hackathons, whatever that means. I don't know what it means. And then she was invited to the White House. Now, I don't know about you, but I don't have a lot of White House invitations. Paul, the voice of
Yeah, we're getting ready to end today to get you out of here on time. If you have any more questions, especially for law enforcement, is there any social workers that have any questions about law enforcement procedures? I know there's never any friction there, so I just wanted to make sure if there were any. Yes, Paula.
I have actually a question for Dr.
Oh, okay.
Because we actually, our agencies, work like here, so you do your job affects me and vice versa.
You got it, Tom.
Oh, I'm sorry. So my question goes back to your statement about something not being suspicious, right, for your guys, when you guys respond. You mentioned something about when you're out on a scene that sometimes you may not be sure or there's not enough suspicion for you to go ahead and make that report. One of the things that I found over the years, having been in the field for probably 20 years as an ER worker and as an ERCP social worker, is we rarely get the call, like on near drownings, from your guys. It's usually law enforcement? Because we understand we have to roll out to the next emergency or what have you. But the way that it affects us is that sometimes we end up having to play catch up for information because you guys have moved on to the next call, and many times law enforcement is, they're busy trying to get the kid together and et cetera, and give us whatever information. So I was just curious as to when you say that, like in terms of training, what training are your folks getting?
That's a good question. So the training that they get, all of our folks are EMT level. They get a couple of hours in their EMT. EMT training is about 120 hours. They get probably 3 or 4 of those hours that talk about child abuse and suspicious injuries and things like that. Paramedics get about 1,500 hours of training in addition to that. There is a module on child abuse as well. And what I meant to say was not that they're never suspicious, but there's sort of, I think in everyone's mind there's a threshold of suspicion that you have. And when a process is difficult, your threshold to go through that process will tend to be a little bit higher. You're probably going to be a little bit more accepting to explain away things. The thought I had in my mind was, abuse victims, it's not written on their forehead. When you look in hindsight sometimes, it's so obvious. But when you look at things prospectively, not so obvious. So does that kind of answer your question? And just to explain the process, and this is per DHS policy about how a case gets reported. Everybody in our fire service is a mandated reporter. They will tend to hand off cases to law enforcement or vice versa, which they should not do. There should be independent reports going through. They'll hand off cases to the ER, assuming the ER will report it. That is not supposed to happen. They're supposed to be reported independently. They have to call the hotline. The hotline telephone call typically, from when I've made the call, takes about 20 minutes. They want information that I never get from patients. They want to know who's living in the back house, what's their name, what's their phone number, what's their social security number, what's their physical description. I mean, all these things that are not part of my history. Then I get the 19-digit number. Then I can submit the online form. Then I have to print the online form and mail it. So when you think about an ER doctor that has to see an average of at least 2.5 patients per hour to keep up, or a paramedic squad that may be running 25 calls a day, you can see how their threshold for reporting is going to go up. And if you really wanted to report more, we just have to streamline that process and make it easier. Yeah, and they will, because I believe down deep we all want to see the number of abuse cases drop and the number of reports go up. We just have to make the process a little more streamlined.
Let me suggest that that's a nice place to end, and we'll sing Kumbaya.
I just had a last comment.
We got a last comment.
About the process. There has been legislation that has passed late last year that allows for online reporting by mandated reporters. It's a pilot, so LA County is going to be entering into that. So the state information notice just was released, and so we're hoping that this online reporting process will help improve that process of reporting. It doesn't allow for reporting of immediate issues. However, it's more of the non-emergent situations. But let's say most of the calls that you handle are emergent, but it'll kind of make maybe the phone lines a little bit easier to get through, and for you to get quicker service because some of the non-emergent situations are being reported online.
I think the next 6 months you're going to see 2 things happen. Fire reports and hospital reports of child abuse are going to be working their way up. And that's mostly with hospitals, infants, some newborn infants, toddlers. The fire department, I assume it has some difference, but we're going to see more of it. And that people will talk about this meeting. Were you there? You were actually there when that stuff happened. Anyway, thank you people for being here. Got mine.